Thank you, Team MISSAB and the chairpersons. We'll be going on the next topic after this wonderful talks by Sajan sir and Ajay and the previous speakers. We'll be talking about the deformity and navigation. Is it something new? I think we have the experience of nearly 1.5 decades personally in standard surgeries, and the outcomes were good. But last almost 3 years, we are doing it with third generation navigation, OAM-based navigation, and it's a great experience, that's what I can say, and newer learning, and a lot of things which really are going to be there with this new innovative technologies. As we all know, I am not going into the detail about why navigation, because we all have we are seeing this now time and again that it is definitely a very useful tool. And in brain surgeries, it initially started, and now in spine surgeries. In OAM, the working principle is basically the image acquisition, the registration of navigated instruments, and optical tracking. Always the questions which everyone has in their mind is it a tool where there is a lot of radiation? Is it going to take a lot of time? What is the learning curve? And is it very costly? So all these 4 things are very, very important that we always feel, but I think it is absolutely necessary to understand. Any institution can buy it, and even smaller institutions can buy this. It's not very costly nowadays. The costs are coming down. It's not time consuming. As you start experiencing, your time starts getting better and better. You really start doing it what you are doing it today with freehand or C-arm based. The radiation, the biggest thing is that there is no radiation to the surgeon. Last 2.5 to 3 years, I have no radiation because all the staff, anesthetist, everyone is out of the theater. Only 13 seconds of one shoot to the patient, and that's also in a low dose, which is equivalent to almost 4 to 6 shoots of a MIS surgery, and that's it. So it's not something which we always think about, and I think that's the way forward. And a lot of literature is coming up with accuracy. Why we should think about that? We have seen there are some breaches, and it's not necessary that breaches will cause deficits. No, but if you have a screw which is almost near there, more than 95% accuracy, you will definitely feel better, because whatever smaller percentage, your outcomes will not suffer. Your outcomes will get better and more refined. We'll go with the cases. This 7-year-old girl, early onset scoliosis, and this girl comes to us. We planned for a deformity correction, as she was progressive deformity, and she was treated elsewhere. And when they referred, we saw the significant deformity, almost 80 degrees thoracic curve, left-sided thoracic curve, and if you see this right-sided shoulder were drooping, pelvis was on the right-sided tilt was there, and apex was at D9. We wanted to do the early onset growing rod. As there is kyphosis, we don't want to do the magnetic system. Therefore, we planned for a standard growth rods. And the beauty of this navigation is you really can go in accurate the pedicle which you plan, and the minimalistic exposures can be done for this, and you really can get away, even in small kids, 4 years, 5 years, 6 years, and that's the beauty of the navigation. And if you see, this is the pre-op and this is the post-op, and we are every 6 monthly we are doing the distraction for this girl. And if you see the corrections, the thoracic almost to 42 degrees, dorsolumbar curve from 38 to 10 degrees, even the kyphosis is corrected. And this is the beauty where we can really get better with this accuracy with this navigation. Challenges, yes. In kyphotic deformities, we always face a lot of challenges. When there is a cervicothoracic deformity, the angulation, the one which we are trying to get the trajectory, and a lot of time the great vessels are in front, the viscera is there in front, we feel that give way, and then we are worried. Where my probe is gone, where my probe is gone, the lenke is gone, and I'm worried. At times we feel that give way, and that's the stress is significant at that time, and that stress will not be there when you're using OAM navigation. If you see almost 120 degrees cervicothoracic kyphosis, and it's a challenging case. If you see on table, the trajectories, everything can be difficult, whatever you plan, but everything, the ultimate plan is on table plan, because after exposure, you see that this is going to be a challenging situation. I will not take much time because we are running short of time. And if you see, the O-arm gives you in one go around 7 to 8 levels in small kids, up to 9 levels in kids, which we have seen. And it's 1 minute show. Just we need to give apnea in such cases. In thoracic spine, the patient no one is inside. This is the first 2D and then 3D. If you're seeing, this is the 2D, and everyone goes out, the 3D is done, and then the real show starts. And we are just following with the navigated images, and with the still station, we are just identifying the exact pedicle, breech pedicle, type 3 Watanabe, type 4. We really can get in, out, in absolutely in the pedicle and in the body. If you see, you have some vessels in front, you have very narrow pedicles. The concave pedicles in thoracic spines are always very narrow at D3, 4. And that problem is always there. But with navigation, you don't have this problem. Sorry. And in this, you can see the trajectory. It's almost touching the ground, but we really can do this very comfortably. There is no stress. I am just looking at it. I am following. Tactile feedback is important. Your expertise and experience is definitely important. It's not that you are just doing it because of the navigation. You have to have the experience of doing these surgeries. That gives you an additional advantage. And in all these angular deformities, severe deformities, you can go up to the tip. You can really get good derotation if you can put a longer screw in these apical levels. And that's what we can see here. I'll just move on. And once you do this, you actually can identify. If you plan for a VCR, you can actually do that. You can check it in the, if you see, this is a very narrow pedicle again, and you really can miss it if you are doing it freehand. But with this, it becomes very easy, and this is what the surgery was. The pre-op and post-op, if you see, significant deformity, and we really got a very good cervicothoracic deformity correction in this young child with the PVCR 2 levels. And this is the beauty. You don't need to take the patient outside. You are seeing it then and there itself, and you are happy with your decompression, with your placement of anterior construct and the screws. All these things can be really dealt very well. Again, a few cases I will just show. And this is a 15-year-old girl, hemivertebra, fused vertebra, thoracic, and very abnormal, obnoxious curve we can see it. And there is negative sagittal balance. Shoulders were bilaterally symmetrical. The cob was 50, but the neck was constantly tilted, and the family was significantly worried for this particular girl child. She was coming to us with repeated follow-ups, and we really could manage. And there were a lot of congenital variations, dysplastic pedicles, but we really can get away very nicely. We can get screws in the vertebrae which we plan, and we can get good correction. If you see the lung volume on the right side, everything gets the best possible option when we are doing it with this. And cervicothoracic deformities are always a nightmare, and we really can do a good job with this. We know that there are chances of misplacement. I will not go into this. A double major curve, again, you really can do a apical screws are important, the concave screws are important, and you really get very accurate placement in such cases. This type 3C, and we really can get a straight, nearly straight correction for this, and we can see the patient's family is very happy post-surgery. All these things, again, it's a great tool for pediatric deformities and scoliosis. And this one interesting case of Angst-Pons cervicothoracic deformity. Young, mid-aged gentleman comes to us with this. He had a fall, and he was brought to the casualty like this. and there was a fracture, cervicothoracic, and it was a very rigid deformity, and this was his MRI. He was quadriparetic, and we were in dilemma what we should do. We planned for anterior surgery and posterior correction at the same time, because he was with only the cord was the support between the head and body. We thought we do a good job anteriorly, first stabilize and turn the patient and do a posterior correction. But it was a nightmare, everything with fiber optic intubation, and this is how you really, I was not very sure whether I'll get something anterior. And this, we were lucky to get the anterior reduction, but it was a challenge to distract because it was not coming. It took a lot of time. There was a CSF, which on reduction we could see that there was CSF which was coming, but we reduced it like a spondyloptosis, putting the cage, and finally that thing which helped us, we reduced it over the cage, and we were happy with this anterior surgery. And we planned for this because it took a long time, almost 6-7 hours. We planned the second surgery after a week. And the patient, for whatever reasons, was not very keen, because he was very happy. He's neurologically he improved. And at 5 days, CSF started coming. Then again, we did a lumbar tap. It stopped, and the patient wanted discharge for various reasons. We explained, but they wanted to go. And he came back after a month, and the lower plate backed out, but the cage was sitting very strong. He was neurologically improved. He was moving his lower limbs, upper limbs, and then we told him that we have to go for a posterior surgery. There was no, the visceral elements were not there, not compressing anything at that lower plate, and we planned for the posterior surgery in this, and navigation really helped us, because that was a great, again, if you see, the deformity was quite rigid, quite significant, and we could put cervical pedicle screws and we could get a good long construct here, and this patient is doing better. These are the things which we all will face, and I think is going to be a big advantage for all of us to have such beautiful navigated technology in future, and I'm sure that this is going to be the future for all of us. Thank you once again.